morning, everybody. Thank you for joining our session this morning on caring for plus-size patients. Our speaker for today, which is Anita Rush. Thank you very much for joining us. If anybody doesn't know, she's a registered nurse and she is a specialist in dealing with plus-size patients. So with that, I'll hand over to her and we'll get on with the session. Thank you.
Good morning, everybody. Welcome. So I've been asked to talk to you today about plus-size individuals. So I'm going to first of all give you a statement because I still find, even in the world today, that we don't really have a good understanding of the management of plus-size individuals. So what we're going to try and cover in this session, we're going to cover the moving and handling of a plus-size person in bed, and from independence to dependence. We all know that caring for plus-size individuals, no matter what environment we are in, is challenging. The risks of injury to both the individual and to the caregivers are significant without appropriate manual handling and techniques and appropriate equipment. What we also need to remember is that all bariatric patients are not created as equal. We have different shapes and sizes, which brings me on to my first part of the presentation, which is about the body shapes. Now, plus-size people come in all shapes and sizes. I'm not going to go into it in great detail because I don't have enough time, but we talk about apples, we talk about pears, we talk about apple panis, we talk about bulbous gluteal regions. All of those are really, really appropriate within the management of plus-size people because that person's body shape will determine the equipment we need. We're not doing seating today, but seating, the bulbous gluteal region would be our biggest problem. Our panis is problem also in the fact that the panis can extend right down to the floor, and when you're trying to move and reposition in bed or even try to mobilize a patient, that panis is going to swing. It's going to be a problem. And we need then to think about tissue viability. We talk about tissue viability as a all part and parcel of manual handling. So if someone has got a large panis, how are you going to manage the skin folds? How are you going to manage that panis so that it does not stop the venous returns when the patient is lying or seating? What equipment are you going to use, like little pillows or something, to lift the panis up off of the legs to be able to continue to enable that venous return? When you've got someone who is an apple shape, that apple shape we know can't lie flat. I don't know about you, but for me, with this COVID pandemic, it's been an absolute problem with plus-size people. I have never had to get so many plus-size people out of hospital. It's been amazing, the amount of plus-size beds that I've had to order and get out back into the community or into the community hospitals. And so again, with our plus-size apple shape, we don't lie them flat. We have to put them up at an angle so that they can breathe and so that they can actually function. What we also need to think about is what type of equipment that we need for our plus-size individual, because, you know, their body shape and their dynamics and their weight, because weight is included, but I'd rather go for weight distribution and body dynamics. Each one will be managed in a different way. So what I want to try and do now is talk about the difference in tissue viability between automated aids and mechanical. So people come to me and say to me, Anita, we've got this patient, he's got tissue problems and we need to reduce the care package. What type of equipment do we need? And I will say to them, well, what are you looking at? Is it a tissue viability need or is it a manual handling need? Because if you're looking at a mechanical need, it still has to be operated. If you're looking at tissue viability, where we're looking at repositioning every 10, 15, 20, 2 hourly, whichever the risk assessment has said, then we're looking at something that is automated. And that makes a difference, because if it's automated and it's something like a Toto, then what you're looking at is putting the patient underneath that, and they are automatically being repositioned throughout the night. However, if you're looking for someone who needs personal care throughout the night and needs to be repositioned with that properly on their side, then you're looking at an automated system. And then we talk about who pays, because tissue viability is primarily health. Automated systems could be health and social. And those are all part of your risk assessment process. They're all talking about, who's going, is it, if it's joints, 50-50 with the Ventilette, or if it's 100% health. When we're looking at automated systems or even mechanical, alongside that, we also need to look at the width of the bed. The width of the bed is really important. With the demonstration that we're going to do in a minute with Ruben, that extra 6 inches added to the width of the bed can make an awful lot of difference in that repositioning. However, if the patient is not repositioned in the right position for personal care to be undertaken, then we have a problem with carers with reach and stretch. Okay, so you've got reach and stretch. So the carers will then start to say to you, this bed is too wide. We are having to reach over the bed to actually get to the patient to do the personal care. And this is where your mechanical system comes, because you can actually move the patient to the edge of the bed and actually undertake the care in a good postural stance. So we need to think about what we are trying to do with that patient with repositioning in bed. The mechanical can also move the patient up the bed. You can also think about the cost. Now, the cost for everybody is important in this day and age. When we think about reduced care handling, we get a patient, been discharged from home, and you find that you need 6 carers, whether that patient is in hospital, whether we've had a safe discharge from home to the community. And we all know, every one of us knows, that we cannot find 6 carers in a care package, in community, or on the ward to manage that patient. So we need to look at thinking, well, what can we do? Now, we can put in simple sliding sheets, but sliding sheets would still need 6 people to manage them. We could put in a silk sheet, but we still need a fair amount of carers to manage that, because what we're actually doing is we're dividing the weight of the load between the number of carers that we actually provide. Now, I do, in the training that I do, I look at independence to dependence. So the number of carers that I would be looking at would actually be decided on the patient's mobility. So if we have a patient that is independent, they can bend their legs, they can move their arms, they can actually help with the repositioning in bed, then we would reduce our carers to possibly 3. If we have a fully dependent patient who cannot bend their legs, who cannot move their arms, are absolutely unable to help as well, then I'm envisioning, based on the height of that individual, the weight and the width of that individual, that you would be looking at 6 carers to divide that weight, that loading between those 6. Nobody can do that. I couldn't even do it where I work. It would be really, really difficult. So what we then have to do is do our risk assessment and think, well, what equipment out there will actually suffice to reduce that care package? Now, we look at, as I said, the sliding sheets. That won't do it. You look at the silk sheets, that won't do it. But do we have a mechanical piece of equipment that can do that? Yes, we do. Obviously, you need to do the research and look at what beds the Ventilette could fit on, or any mechanical piece of equipment. Is it actually fit for purpose? Do the two work together? Or are we actually then thinking, are there other things that we need to do to that piece of those two pieces of equipment to make them compatible? So that is what we need to be doing. We need to be looking. Now, the cost of the Ventilette over a year will actually pay for itself in the number of reduced carers. On the other hand, we've got patients out there on the independent category who actually have got care packages, maybe just for them to go to use the toilet at night, okay? It might be that they could independently get in and out of bed using a mechanical device. Now, I have done this with this piece of equipment. We had a patient who had carers 2 hourly during the night just for toileting purposes. So what we managed to do was we managed to teach them to use the Ventilette, and they then were able to get rid of their carers at night and independently get in and out of bed, and actually then get up when they wanted to, not to have to wait for the carers. It's changed the quality of life for that person substantially. It's also reduced the cost of both human resources and financial to the organisations paying for those carers to go in at night. So this piece of equipment could be twofold. It could help the independent person to remain independent. It could also help you with your dependent. Because what happens is that with this piece of equipment, it will actually also reduce the musculoskeletal injuries. It will also reduce the reach and stretch across the bed. I mean, some people put in 4-foot beds for plus size people. I don't know why, but I don't. I put in 3'6" beds, because actually 4-foot beds do increase the reach and stretch of the carers. So we actually need to think about that as our risk assessment as well. So that's that. Tissue viability. Plus size people do get injured. They do get injured. They get injured by equipment. Just because they have more skin doesn't mean that they are not actually susceptible to tissue damage. They are more at risk of tissue damage. If they get tissue damage, that tissue damage will take longer to heal due to the size of that individual. And what is happening is if you've got a patient who is sitting at the wrong angle in bed, we can conclude the actual capillaries. So they're going to start to get tissue damage on their sacrum. We've got lymphedema, where we've got large legs. And that can also be, some of that causation could be because the pannus is sitting on the legs and we need to lift that pannus up. Sweating. Sweating is a huge one with plus size individuals. What we need to do is look at how we can reduce the risk of them with moisture lesions by when they are sitting up in bed. You've got, when they're in bed, whether or not you can put some gauze or some towels underneath the skin folds to help actually lift them and to absorb the moisture. There are tissue viability products out there that will help you with that. We need to look at the design of the mattress. Is the mattress fit for purpose? And does it actually, is it moisture? Has it got moisture control through it? So all of these things to reduce the risk to that patient that we are managing needs to be considered within the risk assessment. Right, lack of resources. I've already alluded to that. We know that we can't get the carers in. How are we going to manage when someone has got a large pannus in bed? I don't know if you've heard about impact weight, But when we're talking about equipment, we're talking about repositioning people in bed, especially with panaces. We have what we call a terminology called impact weight. So we have to think about how we're going to negate that. Impact weight, if someone weighed 10 stone, if they hit and fall to a hard surface, their impact weight becomes 20 stone. Now you imagine a patient with a large pannus, you've just turned them, repositioned in bed, and their pannus now hits the bed. You have the potential to actually give that patient quite a large injury to that pannus, to the point where that pannus can split. So position in bed, using aids in beds, pillows, wedges is really important when you're repositioning that person because of that impact weight onto the mattress. And that happens with falls as well, but we're not talking about falls today. We're talking about bed positioning. So we need to make sure that when we're repositioning bed, we have enough pillows for that person, that the bed is wide enough, and that we have an automated system to give them the quality of their life as well. Moving a patient on an automated system is far better than actually trying to drag them up on a bed on sliding sheets, because it also gives them that sense of quality of life, I think is what I'm trying to say. You're taking away all those carers, and it's also taken away that indecision about who's going to do what. And if you can imagine having all those people around your plus size person, and especially within today's environment, it's a high risk. So that's what I wanted to talk to you about, really. So we need to put control measures in. We need to think also of the psychological factors of that person. It's coming in 6 carers a day, 4 times a day. How do you think the family feel? How do you think the patient feels? Because they don't know who's going to come to them next. They don't know if they're going to help them. So the psychological factors are really, really important here. Automating, getting that care package down to 1 or 2 carers is fine. I'm a bit loath to keep saying 1 or 2 carers, because there's a lot of tasks involved with plus size people, and not all of those tasks can be automated. So I have to stipulate about the risk assessment. So you've got a patient, you can automate the repositioning, you can automate the turning, but you can't automate the lifting of a pannus. You can't automate the lifting of skin folds. So what your risk assessment might identify that, yes, you could use 2 carers possibly to do the repositioning using the automated system, but when it comes to the actual washing, who is going to lift the pannus? Who is actually going to move the pannus? Can the pannus be moved without being physically lifted? There are tools out there to do that. There is equipment to do that. But my preferred option is always to use sliding sheets, because you can slide the pannus up the bed. If the patient has a huge skin folds, the size and weight of those skin folds, who's going to lift them for the other carer to wash underneath them? So I'm hoping you're understanding when I'm a bit loath to stick it to 2 carers. What I'm saying is it down to the risk assessment and the amount of skin folds that individual has got. Lymphatic legs. We all know that our legs weigh 15.7% of our body weight, each leg. Now, that will increase if that patient has got lymphatic legs and is pear-shaped from the hips downwards. So again, we're talking about bed care, but if that patient has got a dressing in bed, are you going to lift that leg? What can you do to make it easier to do that task for the nurses when they go in? All part of your whole systems approach to managing the plus size person. We've got leg lifters out there. We've got ways of doing it, which is not part of today's session, but that also needs to be thought about. So yeah, we could say 2 people. However, we've got to dress this leg. This leg will need lifting. We've got to do dressings under the chest area that will need to be supported, and we've got to clean under the panas. I hope that all makes sense to you all. All right, so I think for me, I'm a very practical person. I rather do practical than lots of speaking. So I'd like to get on to the practical session. And what I would, if you don't mind, like to do, I would like to do the practical sense, from the practical from independence to dependence. I would like to demonstrate with the help of with Sam and Harry how a patient can independently manage in bed. And it might look a bit haphazardous to start with, but believe me, when the patient gets used to all the buttons and all the controls, they will understand it, and they will be able to do it a lot quicker than we can. So what I'd like to do now is get our modelling, our plus size patient. We would like to introduce him. Hello.
Morning.
We thought it might be a bit more realistic if we had a plus size suit or bariatric suit. Sorry, I call it plus size. A lot of people still call it bariatrics. It doesn't matter. Let's just go with what people are talking. So Ruben is my patient. I've been out to see him, and he's pretty upset because he has carers coming in, waking him up throughout the night for toileting calls. And he has asked me if there's a way that he could independently get in and out of bed and do that call himself and reposition. So we, and this happened, but it wasn't Ruben, I have to say, with this patient, that we managed to get the Ventilette in, and we managed to, it's still in there. It's been in there now for about 5 years. And this patient now is totally independent in their home. Okay, Ruben, what we've got here are a few aids. We've got a rope ladder, which seems these aids seem to be coming back into being. I found them a godsend just lately with plus size people. We've got a turntable, and we've got a tubular padded sliding sheet. Ruben, it's all yours.
So this is the turn sheet here, so that when he swivels around in bed, there's no friction. A quilted tubular slide sheet, so when his legs slide around, there's no friction. And the rope ladder there, so that he can control himself in bed. So what Ruben's going to do is make sure that this is in a position so that when he sits down and rotates into bed, his head is in the right position. So the bed is low down, so he can sit onto the bed at the right height. Then he's going to raise the level of the bed just slightly, and then he can use the Ventilette to pull himself back into bed. So the red roller on the Ventilette has been lifted just for safety reasons, and then he can power himself back into bed using the Ventilette. So go back as far as you can. There you go, and just keep control of yourself using the rope ladder. Make sure the pillow's in the right place, and then you can just swivel yourself around. There we go, and then you can lay yourself back into bed. There we go. If he wants to take that turntable out, or if he wants to make himself comfortable, move into a sideline position, he can use the Ventilette to do that. So you just grab the Ventilette control. The red side is already up, so he can turn himself into a sideline position. And you can get rid of that turntable. There you go. And that is how he would reposition himself on the bed independently. Move himself back into the middle of the bed, do any minor adjustments there. Have you got anything to add to that, Anita?
No, I think that's fantastic. I think that went really well. Yeah, I would say that plus size people, I know Ruben's put the turntable down the top of the bed, but they will have techniques and where they're going to store them and everything. So they will get tables by the side where they can put them on and everything else. So this is just for the demonstration, but there will be those systems in place for them to have done that. So now Ruben is going to get himself out of bed. He's going to actually now get himself out of bed to go to do his daily tasks or whatever he's going to do. What we've got to remember in all of this is that plus size people very rarely can bend their legs. So it's you've got to remember that when he comes out of the bed, they're not going to bend their legs just like we do, that they will probably be splayed dependent on how big they are, dependent on how wide the legs are, because we've had a plus size lady that each leg was 32 inches wide. So I'm not saying that this will work for everybody, but there are cases where in this it can do. And if Ruben wants to, if he really wants to, if he hasn't got enough strength to pull on the rope ladder, he can use the backrest of the bed to help sit him up as well. So it's not just about pulling himself up, because not everybody would have the body strength, upper strength to do that.
So he's just going to slacken the sheet off there so that he can then profile the bed a little bit. That just gives him the extra height to then pull himself up on the rope ladder. Then he can just do exactly reverse, pull himself out of bed. I think you need to tuck the midriff back in, Ruben. Apologies. He can power himself out of bed now using the ventlet. Wants to lower the bed down so his feet are on the floor. That'll do. And there we go.
Any questions? What can I ask? What degree the backrest raises to?
So the bed is a normal bed. I should have made that clear. The bed is a standard community style profiling bed. We probably should have done the demonstration on a wide bed to make it more realistic. But yeah, to give a few examples, the SB755 wide, the Bradshaw bariatric, those sort of beds are all compatible with the ventlet. So it will go up to a normal height. As long as you've got enough slack in the slide sheets, we can profile the bed as much as you like. So the normal profiling functions of the bed are still operate fine. I trust that answers the question. Any other questions coming through?
I've got a question.
Okay.
What if Ruben needed some wedges or pillows? Could he have had them next to him before he went down himself? Because he may need to, yeah. So he could have done that.
Yeah.
Yeah.
So the next demonstration, as Anita said, is showing you somebody that's completely dependent. So we'll get Ruben to get into bed and then pretend he's totally dependent. Then Sam is going to be my second carer, and we're going to go through how to manage somebody in bed that's totally dependent, how to manage the pannus, how to move heavy legs, etc., using a slide sheet, etc. So I'm just going to neaten up the ventlet, and then we'll get Ruben back on the bed. So, do you want to jump back onto the bed, Ruben? So, as always, we're going to raise the bed up to a safe working height to preserve our lower backs. So, about the height that I can then rest my arm onto the bed without moving my shoulders. So about there is good. So Sam here's my second carer. Good morning. So I can move Ruben across to the other side of the bed. That way I've got a bit more space on this side of the bed to add my wedges and pillows, etc. So to help the top leg slide over properly, we're going to put what we call the lie-let pad higher here. That's going to take the weight of his leg, and then we're going to put this tubular slide sheet in between the legs so that his top leg can slide over without causing any damage. Then, to take the weight of the panos, Anita was talking about impact weight earlier. We don't want that panos crashing down onto the mattress, so we're going to use the wedge here to take the weight of that as it comes over. So we're going to put it in this way round, in next to the panos. If you cross your arms, Ruben, to prepare for the roll, we can put this in there, not too tight because we don't want to inhibit the roll. We just want to take the weight of the panos as it comes over. So if I lift the side rail, then I can start a turn. I can be here managing the panos. Adjust this pillow. There we go. And Sam's adjusted the top leg. So that's a nice stable position there. This panos is nice and supported there. The height of the pad high gives them a really neutral hip position. A lot of people that are plus size, because of the limited mobility, there's a lot of pain in the joint. So that's going to take off a lot of pressure across the hip there. Have you got anything to add, Anita?
No, that's a good sidelining position for him as well. And the reason that I cross the plus size patient's arms at the top rather than lay the arms out like we would in some like a recovery position, a lot of plus size people find that more comfortable. And what we've got to remember, the more body mass they have, the more their limbs shrink. So putting their arms out like that, like sideways out, can become very painful. So that's why we cross it. But that is a good position. The panos is well supported, and the legs are well supported. And Ruben, be honest, is that a comfortable position for you?
Yes. Yep, I think that.
Yeah.
Positive answer.
Now, in that position, if Ruben had a big panos in that position, I would take the wedge out, and there I would put sliding sheaths in, and I would slide the panos up so that I could clean. So where Harry is, he would be able to look at the tissue that side, while me as the carer, I'm this side, sliding the panos up with the patient. And then we would do the reverse. We would turn the patient over, and then I would interchange the roles to reduce the fatigue of the carers who are undertaking that task. Another thing you could do is, if you were trying to catheterize, you could bring the patient right to the edge of the bed where Harry is, increase the lift, and you can then move the bottom and do a catheterization from that angle, which another way of doing it is obviously in the acute trust. You can take the edge of bed down off, and you can bring the patient right down to catheterize. But this is a way we can do it in the community, is another way of communicate catheterization. What I'd also like to say at this point is that we did a cost analysis in Berkshire, which Sam was included in, and a colleague of mine, Jill Crichton, was very involved in this. And we had the patient that I was talking about, we purchased the piece of equipment, but the annual savings for the social services was £116,800. That was with the reduced care package for this patient. So over the time, there are those considerable savings.
That's very, very good. That's a very good example. So a lot of people look at the vendlet. the Venlet for plus size people is called the Venlet Barry or the Venlet V5S. A lot of people look at that and say, well, it's £9,000, it's extremely expensive. It is expensive, but when you've got that level of savings and you're improving people's lives in that level, it becomes immaterial. Anita was talking earlier about the resources, the human resources and the monetary resources. And with this piece of equipment, you can save on both of those resources. The question about personal care. So when I'm around this side of the bed, I can move Ruben back into the middle of the bed in this side-lying position. He's stable there because of the use of the Lialet cushions. I can lower this side route, and then I've got full access to personal care. I can dress wounds, I can change pads, etc., do any cleaning of skin folds or anything like that.
And one of the main things we've forgotten to mention, Harry, is putting a sling in.
Yes.
Putting a sling in for a plus size person or anybody. We're talking about patients here with complex needs. We're focusing on plus size, but putting a sling in is so simple using the mechanisation of the ventilet. You place it down the back, you reposition, turn the patient, and it is just another. It's not going to cause the carers a lot of fatigue when they're pushing and pulling to put a sling in, when they are trying it with sliding sheets. This is just so the carers don't go home so tired. Let's put it that way.
Very good. Okay, have we got any more questions?
Sam, can I ask a question? It's Emilio here. I just wondered, is the Vendelet the whole bed frame that we see, or is it a mechanism that's an add-on to an existing bed frame?
Yes, good question. So as I said, the bed is exactly the same as a normal bed. The side rail is what you can see here. These side rails here, and you've got the initial hand control that you've seen. And there's a control box under the bed. The sheet, the turn sheet here, which is going around the rollers, and an integrated slide sheet which has been attached to the mattress, which is underneath to create that slippery surface. The bed frame that you can see underneath, that's just your standard bed frame.
So is it compatible with many beds?
There's a full list of bed compatibility. And we can send that round on the email following this. Oh,
that'd be really useful.
If you've got service users, clients, residents that are that you think would benefit from a Vendelet, ping us a note and we can run through a list of points to make sure that whether it's going to work or not, and that includes bed compatibility.
Oh, okay, that'd be really handy. Thank you.
Very good. Any other question here?
Nicola Holland, yes, absolutely. And apologies for that. I should have said we have to move the head as well. But we could possibly have thought the patient could possibly move their head. So I'm waffling here to make up the excuse that, yes, we should have done that. So apologies. Rebecca, I think, if I'm right, Harry, that you've got all the cost savings on your website, haven't you?
Yes, that's another resource that we'll send around after the webinar on the email. We'll send around the recording, we'll send around the bed compatibility list, and also the cost benefit calculator. So you can put in your cost of your current care package, or what a care package would be, and also what you can cut it down to, or what you believe you can cut it down to using the Vendelet system. Then it will give you the savings and how long it will take to pay itself back, etc.
Harry, could you explain changing the sheet?
Yes.
Please.
If anyone wants more detail on the Vendelet itself, there's been some webinars on just the Vendelet itself, so there's lots more detail on there. Just quickly, the turn sheet is attached to the roller bar using Velcro, so you just unwind it all the way. My hand control here. So just unwinding the sheet here, we'll unwind it all the way, then it just, you can just unattach it from the roller bar using the Velcro. So just like that. I trust that helps. Then reattach the new sheet and roll it back on. As I say, there's lots more details on the website if people want more demonstrations. If they want demonstrations from their own team, for their own OT team or their own care team, I can set up a separate meeting for just your team, or there's plenty of resource on our website.
Does the bedding, does the patient sleep direct on the ventilator, or is there bedding?
Yes, so in terms of sheets, you'd have a duvet or sheets over the top if that's what the client wants. This sheet is a nice, thick, comfortable cotton sheet, so, and this is what they sleep directly on, yes.
How would you get a padding? You've already explained that, but with a combination of maybe a sliding sheet, the pads will be quite easy to put in, as would the slings, yes?
Yeah. So when you've got a good sideline position, you can align the pad in behind and just go back into a supine position and it's in.
Sorry, Anita, can I ask one more question?
Mm.
Yeah, does it work in conjunction with a dynamic mattress?
Yes.
It does?
Yes, I use them with dynamic mattresses.
Oh, great.
The mattress we've got here is a foam one just for ease of demonstration. We find that most people that qualify for a Vendlet would be on air mattresses.
Okay, thank you.
Another one is, do you trial the equipment, Harry?
Yes, yep. So we're going for a 2-week trial. That's all free of charge, and then to see if it works, and then it will remain there if the trial has been deemed successful.
How many sheets do you get with a package?
So this there's a few different packages you can buy with different accessories, but the standard one is 3 turn sheets and 2 of the slide sheets. So you got so with the 3 turn sheets, you've got 1 on the bed, 1 in the wash, 1 ready to go, and you can buy additional sheets if you need.
Yes, it's about continence. Yes, I understand that. We have these. We have the Vendolets on our core equipment list where I work, and if the patient is quite significantly incontinent, we do use the disposables. But otherwise, we do use the cotton ones, and they can be washed. There's also an incontinence sheet that's designed to go with the Vendolet. It's called the Incolette sheet. It's quite large. It can take 3 litres of fluid. So that can go, again, so we get a sideline position, we can tuck that underneath in the same way. And because of the size of it, when you roll somebody into a sideline position, anything that's soiled is going to roll onto a clean part of the sheet rather than onto the bed clothes. S-leach, would plus size people have a frame ready in front of them to stand to? Yes, if they were independent, they would have already done all that positioning before they'd got into bed. They wouldn't have it in front because they would have to swing their legs round. They'd probably have it at the top of the bed, ready to drag it round in front of them when they are ready to stand. So because they need that space to swing their legs round, they would have it somewhere at the top. I know it's really interesting, isn't it? Because within the environment, you're now talking about having a frame. They probably might have a bedside cabinet. They might even have an overbed table. It's all that other pieces of equipment that are around that bed that actually you've got to think of the functionality of all of this working, which goes back to what I'm saying is the mechanics, the Vendolet is fantastic, but it's what else is in that environment with it.
Yeah, that's very helpful. Thank you very much, Anita. I think we've run out of time now. I'm sorry we've run to 50 minutes, but it's been very, very good questions coming through. Lots of good content. Thank you so much for coming on, Anita. Thank you everybody else for joining. I hope it's been useful. Keep in touch for future webinars. As I say, we'll be sending all those resources plus the recording round after the webinar. Keep in touch for future webinars. We've got dementia ones coming up. We've got ergonomic tools for clinical reasoning, etc., for when you're putting in pieces of equipment. Lots of good content coming up, so do keep in touch. Thank you very much.
Thank you.